Our next speaker is Dr. Alan Cruz, who's chairman of the AMDAI Scientific Advisory Panel, and he is also professor and head of the Department of Ophthalmology and Visual Sciences at Dalhousie University and the district chief of ophthalmology at Capital Health in Halifax, Nova Scotia. It's my pleasure to introduce Dr. Cruz, and I know I mispronounced that. There you go.
Thanks very much, Mark. Thank you, Mark. Sir David and ladies and gentlemen, other members of Parliament, thank you very much for this honor and privilege to address you about current and new treatments of AMD. I hope to hold your attention for less than 10 minutes. I'm not sure I will hold Dylan's attention for less than 10 minutes, but he's been a very good boy in the front row. So to start with, this is the conception from Joan Miller's brilliant mind, who is the professor and chair of the Department of Ophthalmology at Harvard Medical School, when she gave her Jackson Lecture at the American Academy of Ophthalmology in 2012. And you can see that on top of normal aging, with a genetic susceptibility and perhaps environmental risk factors like smoking, and there are a number of pathological processes that we're still working on that lead initially to what we call intermediate AMD, which really the hallmark of which are yellow drusen-like excrescences that we can see on fundus examination when we look inside your eye. And for those of you who don't know me, my day job is I'm in my clinic 3 or 4 days a week treating patients with age-related macular degeneration. So I'm in the trenches, so to speak. And then from there, you see at the top bar is GA, which that's the medical term for dry macular degeneration, so-called geographic atrophy. And on the left-hand side of the slide, neovascular AMD, which is the proper medical term for wet macular degeneration, so neovascular AMD. And really, the conception is that this is probably a Venn diagram. It's probably one disease with overlapping susceptibility to geographic atrophy on the one hand, dry AMD, wet AMD, neovascular AMD on the other hand. This slide is quite complicated, but if you want to see what we see when we look in at dry AMD, look at the bottom left slide, which shows atrophy or geographic atrophy of the retinal pigment epithelium in the macula. On the right-hand side is a patient with end-stage macular degeneration, mostly wet in this case, where there's a large fibrovascular scar blocking the macula. And in the middle is an example of a patient that we would be actively treating with neovascular AMD, with a pigmented membrane that you can see smack dab in the center of the macula, surrounded by subretinal blood and fluid. Above, the panel above in the middle with the arrows, the green arrow and the black arrow, those are the drusen I mentioned earlier. And we now have very sophisticated, almost cellular level imaging capabilities with so-called optical coherence tomography. These are scanning laser ophthalmoscopic technologies that allow us almost a cellular view. The arrows, the yellow arrows, are pointing at reticular drusen between the photoreceptors and the pigment epithelium. Very, very fine resolution. So we're actually optically being able to see really histology now, which is really advancing our ability to diagnose and treat the disease. But prior to 2001, my area of clinical research was actually in the treatment of this disease. In the late 80s and early 90s, we funded a clinical trial in Canada looking at wavelength selection of thermal photocoagulation, which caused chorioretinal scarring. It was a destructive therapy, but if the neovascular membrane was off-center, we could treat it effectively, but only in less than 10% of patients with wet AMD. The problem was, as soon as the neovascular tissue got into the center, then we were doing more harm than good, and our treatment was associated with vision loss. But as of 2001, thanks to the research discovering this dye verteporfin in Vancouver, and then followed up and made clinically applicable at Harvard by Joan Miller and her colleagues, we had what's called photodynamic therapy, where we infused a drug, verteporfin, in the vein of your arm for 10 minutes, waited 5 minutes, and then shone a diode laser light, an infrared laser at 689 nanometers, and that triggered the drug to work and to thrombose the abnormal blood vessels in neovascular AMD. And for the first time, we were able to reduce rates of visual loss to all comers, really, with wet AMD. But it wasn't really until 2004 that we had, as Keith mentioned, our first anti-vascular growth factor drug, which required injection into the eye. And this drug was the first time that we really were able to slow the progression through a biological therapy of the disease. But unfortunately, we didn't reverse visual loss, and we didn't really maintain excellent vision. It really wasn't until the blockbuster drug ranibizumab or Lucentis was approved by the FDA and European agencies in 2006 for neovascular wet AMD that we really could change the game and preserve vision in over 90% of patients treated. Come 2012, we saw aflibercept approved, which is now called Eylea in the marketplace, marketed worldwide by Bayer, and was shown in 2 pivotal clinical trials to be non-inferior to ranibizumab, which basically in medical terms means pretty much the same, but not superior. But the key here was that Eylea in these pivotal clinical trials only had to be dosed every 8 weeks as opposed to every month. So that raised the hope and the possibility of huge cost benefits to the health systems and to payers of these drugs. A new drug that's being investigated that has everyone's attention right now is an inhibitor of platelet-derived growth factor, another growth factor that stimulates neovascular AMD, called Fovista. And in a head-to-head clinical trial that was reported recently, in a phase 2 clinical trial, in combination with ranibizumab, for the first time we saw results that were actually superior to ranibizumab or Eylea alone. And these phase 3 trials are underway, and we're anticipating the results in the next year or so. So along comes a new technology now with 2-year results, an X-ray technology which is seen as an adjunct to antivascular growth factor therapy that Sir David mentioned, the Araya therapy. And this is a stereotactic radiotherapy technique with the apparatus visualized for you on the slide that's intended as a one-time, one-session, low-dose, low-energy X-ray source to maximize safety. And the procedure duration takes about 20 minutes. And you can see that in experimental studies looking at how the radiation in combination with antivascular growth factor drugs affect endothelium, which are the lining cells of the blood vessels, fibroblasts, inflammatory cells, and the pericytes, which are the wall vessels of capillaries, you can see that in combination there's a sidal effect, there's a very profound synergistic effect on the right-hand bar with these drugs. And in the 2-year study, fully 51% of the target population treated with both stereotactic radiotherapy and anti-VEGF only needed 1 injection, a mean of 1 injection over 2 years, versus only 15% of the controls receiving injections got into that 1 to 3 injections. The rest of them needed more injections. And as you can see, one of the big things actually has been alluded to already is patient fatigue. Fully in the United Kingdom, we understand that fully 50% of patients by the year 3 are starting to drop out. They're being lost to care because of this burden of returning to the clinic regularly for injections, and I deal with this pretty much on a daily basis. And we know how expensive these new drugs are, costing the United Kingdom at least £220 million in 2012 just for the drug costs alone. Capacity is an issue with over 500,000 injections required in the year 2011-12. So the hope is that Araya therapy and technologies like this may reduce patient fatigue, free up capacity in clinics, improving access to care, as Sir David mentioned, and saving the payers money, which at the end of the day will sustain our system. So in conclusion, the last decade, and this has been very exciting for me because in my clinical research has always been in this area, the last decade has seen enormous progress in the treatment of wet or neovascular AMD, less so with atrophic or dry AMD, although much promising research is underway, which is beyond the scope of today's talk. It's likely naive, though, to assume that future treatment strategies will continue as a form of monotherapy, like ranibizumab every month or even Eylea every 2 months, with one drug or treatment technology only providing the magic bullet required to preserve and enhance vision. Therefore, new technologies, as we've heard of today, like Araya, that reduce treatment burden or reduce the aggregate number of treatments required, or increase the intertreatment interval, will be highly valued both by patients and by payers alike, especially if they provide incremental cost benefits while preserving and enhancing quality of life. Thank you very much. Thank you.